I am thrilled to introduce our next speaker, Rachel Solotaroff from Community City Concern. Do I have it right? Central City Concern, which is an amazing organization that I'll let you talk a little bit more about. Rachel is practicing and now CEO of Central City Concern in Portland, Oregon. And as many of you know, Oregon was sort of ahead of all of us in terms of the opioid crisis, opioid-related deaths. And so we've been using materials from Old Town Clinic, which is where Rachel was practicing starting, I think, in 2006. So we are greatly indebted to all of their work, and you'll hear about it from Rachel. So thanks.
So thanks for having me here. I'll tell you a little bit about our organization briefly and this idea of recovery-oriented persistent pain management. So I work, as Jen mentioned, I work in an organization, Central City Concern, whose mission is to provide comprehensive solutions to ending homelessness and achieving self-sufficiency. So to that end, we do housing, we do supported employment services, we do primary care, addictions treatment, mental health treatment. But what is really notable about the organization is about half of our staff are people who would self-identify as being in recovery. And that's from the custodians to the executives. It's a key part of the culture of the organization. And when I say recovery, for some folks that may be recovery from a substance use disorder. For some it may be recovery from trauma, from serious mental illness, from homelessness. And so when I got to this organization in 2006 and started seeing how we were managing pain, it didn't seem to have that same sort of recovery orientation. So over the last 11 years, we've tried to put together a program which reflects some of those values and practices and principles of recovery, but focused on people who have an experience of pain. So to that end, what we'll try to do today is I'm going to build off of the wonderful foundation that Vanessa gave and give you a conceptual framework for understanding not just substance use disorders, but also persistent pain, using these pathways of reward, but also this idea of anti-reward, or what we call the dark side. And then talk a little bit more about what recovery-oriented pain means. I'll tell you a little bit about our program, which is a healthcare for the homeless clinic at Old Town Clinic in Portland. And then hopefully we'll have some time, and we can play with these a bit this afternoon as well, to go over the toolkit that we have developed that we use in our primary care practice, some samples of which are on your table and will be emailed out to you, and any resources that I have that might be of use to you are yours for the having. Okay, so in case in the last 18 hours since you've been at work, if you're a primary care provider, you have forgotten what some of the challenges can be in taking care of folks who have substance use, may or may not have substance use disorder, do have persistent pain, may or may not have trauma. I've made a little video with a colleague of mine to remind you of what that experience is like. I'll tell you before we start the video, though, I got feedback about this once. The video is poking fun at somebody, and that person is not the patient. The video is poking fun at me, the primary care provider in this, and I'll explain why afterwards. But this patient is actually, this is a colleague playing this patient, but was a real person who's an extraordinary woman who has taught me a great deal. So just wanted to give you that proviso before we watch the video. Well, hello, welcome. What do you prefer I call you?
Lainey's fine.
Okay, Lainey. I just go by Rachel. We're really laid back here at the Safe Space Clinic. My last name's a total disaster anyway. So,
this is Chloe, by the way. She's my companion pet.
Yeah.
She goes everywhere with me.
Okay.
Yeah.
I'm not usually super into pit bulls, but that's honor your
bringing what keeps you safe here. So anyway, I have a ton of questions I could ask you, but what's most important is what's important to you. So tell me, what brings you into Safe Space Clinic today?
Okay, well, I have a head injury, so I have my memory doesn't work very well, so I have a list here.
Oh,
so
okay,
I'm just gonna
okay.
is that okay?
Yeah,
Can I get
oh,
that out,
yes,
or-
thank you. Thank you. That is so helpful.
Oh, here.
Oh, yeah, okay. Okay. Oh, wow. Okay, so that's a pretty, let's see, that's a pretty long list there. So we've got about 20 minutes or so.
Well, I mean, there's
so
there's a lot, and I need for you to get like a full picture of what's happening for me. Otherwise, you're not going to really understand. And so,
Okay.
yeah.
Okay.
So I have it all written
Sorry,
down.
I'm
so I just
sorry.
wanna
I'm
make sure
sorry. Go ahead.
we
Go ahead.
over
Yeah,
it.
of course, of course.
So, first of all, I've been in like a lot of car accidents. I've had a lot of
Okay. Oh, I'm just
broken
logging
bones.
on here.
Okay.
Yeah. Okay.
I've got osteoporosis.
Oh, okay. Have you tried?
It's
Fossil?
degenerative.
Oh, I see. Okay.
Yeah.
Really, I haven't heard of Okay.
My bones are like crumbling. It's
Okay.
so painful.
Okay.
Yeah.
Any bones in particular? Is it your knees, your legs?
Well, I
your-
mean, yeah. I mean, I've got
the
like
discs in your.
I have
back?
degenerative discs in my back.
Okay.
I've got really bad
okay.
neuropathy.
Oh, is
If
that
you could
from
see,
diabetes? Okay.
if you could see my legs,
Yeah.
they're like red and like the veins are sticking out.
Is it like a circular? Do you get cramping when you walk with
Mm,
them?
no,
Is it-
no.
oh,
It's like I
okay.
have arthritis.
Okay, let me just get your chart here. Okay.
I have
Alright.
arthritis in my shoulder.
Oh,
My physical therapist says I need to like not go to physical therapy for it.
Okay, so have you been to
I'm
physical
sorry,
therapy?
this is just really like
Okay.
I feel kind of overwhelmed right now, and I'm just like in a lot of pain.
Yeah,
So
no, I hear you. So tell me, well, what have you tried that helps for your pain?
well, like in the past, I was on methadone for a while, and that
Oh,
sort of
was that at a methadone?
it was at a
clinic?
methadone clinic. I did
Oh,
that for a really long time, and then I was like,
How
I don't.
did you get into the methadone clinic originally?
It was for pain. I went for pain, so it
Oh,
didn't feel
okay.
appropriate.
Did you ever use any injection?
No, I mean, not really. I needed pain management, and that's what they wanted me to do. So
Okay.
Anyway.
Usually that's more for. Okay.
anyway, I left that clinic because I wanted to get off the methadone because I don't abuse drugs, right? So I needed something like legit for my pain. So I went to another clinic, and they gave me OxyContin.
Okay. Well, how much of that were you taking?
I was taking 5 tabs a day.
Okay.
And
what's of
another, they also.
10s or 20s
I
or the
I have it
30s?
in another list somewhere. I don't remember, but I
Oh.
can give you that at some
Okay,
point.
that would be really helpful.
Anyway, they also gave me Lortab too, which was also
with the OxyContin on both of those.
yeah.
Okay, all right. So that sounds like quite a.
And
bit.
also, I just wanted to also just let you know that I have like last time I was at the ED, they told me I have an abnormal heartbeat.
Oh,
so,
okay. Did you get an EKG there?
Actually, I
or-
didn't make it to that, but
Oh,
I did
okay.
get my last MRI. They looked at my heart and they said it was fine, but it always feels like I'm like having a heart attack
Okay, on your MRI. Okay.
or something.
Well,
Like,
are
I don't
you
know.
having chest pain right now?
Yeah, I mean, I
Oh.
always feel like my heart's racing, and
Okay.
I mean, I feel really nervous right now, and
Okay.
this is hard for me to be
Okay.
sharing all this stuff with you. But
So, maybe what do you do maybe that helps to calm you down or give you some kind of pleasure in your life?
well, I mean, I used to volunteer, but I can't really do that anymore
Oh,
because
okay.
I can't leave my home. I have a lot of anxiety. I've got agoraphobia.
Oh, wow,
Sometimes I'll
okay.
just be like stuck there for days.
Okay.
I
you-
feel suicidal a lot. Like,
okay. Wow. Do you feel suicidal today?
well, yeah, like I
Okay,
feel it
all
all the
right.
time. So,
So,
I have like a
have
lot of
you-
trauma and stuff.
Yeah.
So,
Have you met Lydia? Yeah, she's
don't
one of
know
our behavioral health.
oh no,
providers.
I've got a counselor and I've had a psychiatrist. So, and they prescribe me
Yeah.
lorazepam and Klonopin, and so
Oh, they
I'm
do.
set there. So I don't need to see I don't need to talk to another person about it. That
Okay,
seems to
okay.
be like kind of ridiculous. So.
Yeah, I know. I hear that you've got some other supports there, but here at our clinic, we really work as a team to try to understand how all different parts of our experience affect our pain. So why don't you just sit tight for a sec. I'm just gonna pop out and get Lydia. She's gonna be super helpful to us here. So just sit tight. Oh, hey, hi, Chloe. Okay, just sit tight there.
So if we had more time, we'd have an opportunity for some discussion. But I'll tell you the two things that, as we were playing around with this video, that came up for me. One is that you don't get much training around this intersection of pain and addiction and trauma, I think, which we can see are all alive for Lainey. And I think what we've tried to substitute, really in primary care, is just being there and being a good listener. And that's great, but it really only gets you so far. And so I sort of embarked on this journey to try to understand, just as I would for a patient with congestive heart failure or uncontrolled diabetes, I kind of wanted to understand what are the mechanisms, what's driving their symptoms, as it were. And I think the other thing, which somebody pointed out to me yesterday, is that the original sin in this video is that that clinicians desire to start diagnosing and problem solving and diving down every rabbit hole of every differential diagnosis. And instead of just sort of being, as he described, humble and curious and trying to understand the totality of what's going on here. Okay, so given that, tell you a little bit about what I have learned, particularly from the Addiction Society here in California. And I'll talk about pain in a moment, but I'm going to dive back initially into some of these ideas of reward and anti-reward that Vanessa talked about. And sorry, one more caveat. I'm not saying in doing this that every person who has persistent pain has a substance use disorder. It's just that the pathways involved are remarkably similar. And what we'll do here, so backing up one. So as we look into the world of pain, there's been a lot of work in the last 10, 20 years, we don't have the time to talk about today, about this idea of central sensitization, of how your sensory experience of pain and persistent pain amplifies in a fairly short period of time. But some newer research has shown that as we move from acute or subacute to chronic and persistent pain, other parts of your brain start to light up. Not just so much your sensory motor cortex, but particularly the parts of your brain that are involved in emotion and reward. So the work that I'll summarize here is the work of Dr. George Koob, who I think of as like the Robert De Niro of the neurobiology of addiction, like he to whom all else shall be compared. And the beauty of this is that he's boiled down addiction into 3 primary pathways, which he has graciously color-coded for us. And we'll go through each of those in the next few minutes. So one is this binge, okay, I don't want to turn this off, is this binge intoxication phase, which is blue. That's the more euphoric part that Vanessa was talking about. And then his big addition here is this idea of the withdrawal or the negative affect, or what he calls the dark side of the addiction in red. And we won't have much time to talk about this green phase, but that's the idea of preoccupation or anticipation, kind of how our prefrontal cortex, this big part of our brain, which is why we have to have this big forehead, which allows us to do rational thinking and problem solving and executive functioning, which becomes impaired in substance use disorders as well. So here in the middle, here we are in the blue, this fun binge intoxication phase, and this central place here is the nucleus accumbens, which Vanessa talked about. And this is what Dr. Koob calls the grand central station of reward. It's the place where all of our neuropeptides and helper neurotransmitters converge. You've got dopamine, you've got our own endogenous endorphins, GABA and serotonin, all converge on the nucleus accumbens, which is where we lay down habits and learning and cues. And when dopamine fires, in particular in the nucleus accumbens, in early stages of substance use, you get pleasure from that. You get euphoria and projections up into the dorsal striatum and the thalamus. But the cruel truth, the harsh reality of substance use is that if you overdo that reward system, if you dump more and more dopamine into it, there's payback in your brain. This idea that what goes up must come down. And over time, as you stress that, as you overdo that reward system, that nucleus accumbens loses reward properties and instead gains stress properties. It doesn't really change from blue to red, but that's sort of the idea to illustrate here. And that instead of projecting up into these pleasurable pathways, the nucleus accumbens now starts to send its projections to the amygdala, right, to that little almond-shaped structure deep in your temporal lobe, which causes fear and anxiety and fight or flight. So the cruel truth here is, as Vanessa pointed out, there's payback in your brain when you overdo your reward system. So here's a conceptual model to try to get at what we're talking about here. It's Dr. Koob borrowed this from a psychologist named Richard Solomon, and it's called the opponent process. It's two processes kind of working in balance or in opposition to one another. And one process is the A process, and one process is the B process. And think of the A process as that which makes you feel good, and the B process as that which makes you feel lousy. So think about if you are in a non-dependent state around a substance. Let's say you go to a wedding and you have a couple of drinks and you start to feel a little disinhibited and you do like the moonwalk and like bad dance, whatever. I'm almost 50, so it's the kind of where I'm coming from. And you get this nice peak in A, this nice boost of feeling good, of euphoria. And in the morning, you wake up and you're a little bit hungover and you're pretty mortified at what you did on the dance floor. And you start to get this sensation of B, the B process of feeling kind of lousy. But that B process pretty rapidly, it doesn't go too deep, and it pretty rapidly returns to baseline. Oops. Now, once you become dependent on a substance, you can use a lot of it, and the A process, that feeling of euphoria and of happiness, is largely suppressed, even as you use more and more. And instead, what you have is a much more pronounced kind of trough of this B process and a much slower return to baseline. So it's just a conceptual model here. And what George Koob, his discovery is to help us understand what is the B process in addiction? What is it that's making people feel so lousy and exhibit some of these behaviors we talked about earlier, lying or rapid escalation, or things that you all have recognized. Well, one is just that the absence of that A process, the absence of those neurotransmitters that make you feel good, those going away in and of itself make you feel lousy. The absence of dopamine makes you depressed and dysphoric. The absence of your own endogenous opioids puts you in pain. Absence of serotonin makes you depressed. The absence of GABA makes you feel anxious and panicked. But unfortunately, in addiction, not only do you have the suppression of the good guys, you have the upregulation, the activation of a number of other anti-reward neurotransmitters that circulate anyway, but are usually in fairly low or episodic levels in our brains. So one is you get an upregulation of dynorphin. Dynorphin is sort of the poor step cousin of the endorphin family, the one that acts on kappa receptors and makes you feel pretty crappy. You get an upregulation of corticotropin releasing factor, of the stress peptide that drives your whole HPA axis. You get an upregulation of norepinephrine, causing increased stress as well. So again, when you think about Lainey sitting there in that exam room, part of her distress is fueled by a lot of these neurotransmitters that she is living in a constant state of every day. And I don't have time to talk about trauma today, but those of you there's a lot of behavioral health experts here, know that a lot of these things are sort of chronically upregulated in people with traumatic histories as well. Okay. So this will be, I promise, this will be the last brain picture I show, but keep that framework in your mind. We're going to come back to it in a moment, of reward and anti-reward. So let's switch gears for a second and let's talk about how the reward pathway functions in pain. And we're going to boil it down kind of similar to just 3 simple neurons, some of which you're already familiar with. So the first one that we haven't talked about yet, but the ventral tegmental area, which is part of that limbic system, part of your sort of primitive reward pathway. And I should give credit for all these slides. So there's a researcher named Jody Trafton at Stanford, and I saw her give this talk at the California Society for Addiction Medicine once, and I was like, oh, that's the first person who has had this make sense. So I emailed her and said, can I shamelessly steal your material? And she said, yes. But she's right here in your backyard. So the ventral tegmental area is part of that reward system, and it's the part of your brain that goes out into the world and looks for opportunities for reward, or if we're thinking about pain, looks for opportunities for relief. Ventral tegmental area comes back and talks to the nucleus accumbens, remember the grand central station of reward, wherever, and if the VTA gives the nucleus accumbens a nice big dopamine signal, nucleus accumbens says, oh, okay, that looks like a worthwhile opportunity to take. Let's go for it. Let's do that action. Now, the ventral tegmental area also sends signals up here to the frontal cortex. And the frontal cortex actually has the ability to inhibit that nucleus accumbens from making that decision. But unfortunately, our frontal cortex is very fancy, and so it's very slow. And if things are happening too quickly down here in the reward system, in your limbic system, there may not be time for frontal cortex to step in and say, wait a second, that sounds like a decision that's good for the next 5 or 10 minutes, but not a good decision for us in the next day or month or so. And that's where we start to get into this push and pull around relief seeking in persistent pain. Okay, and again, the mediator here is dopamine. The larger the dopamine input, the more you dump dopamine into these systems, the more likely you are to seek a relief-providing behavior. So you can see how this is sizing up, right? We need our reward system. It's a crucial part of crucial primitive part of us. It's allowed us to eat and sleep and procreate. But if it gets out of balance and takes over, we end up like Laney. We end up anxious, we're impulsive, unable to tolerate distress. And newer research has shown that not only addictive drugs, but the search for pain relief, the search to get out of physical or emotional distress, can dump lots of dopamine into those reward circuits, and then that tends to drive habitual relief seeking. A colleague of mine called it, you get on a dopamine superhighway. And those sorts of circuits are moving so quickly, the frontal cortex doesn't have time to step in. Okay, so let me give you an example that's a little more concrete and isn't a brain picture. So think about, and one that's sort of more grounded in pain. Think of if you hurt your back doing whatever, I guess we're in California, so yoga. I'm from Minnesota, so I was always like, shoveling snow, but we don't do that here. So you hurt your back, and your reward system is like looking for relief from your back pain. So your ventral tegmental area goes out into the world, and it sees the couch, and it says, wow, this looks like a good opportunity for relief. And it sends a nice dopamine signal to the nucleus accumbens. The nucleus accumbens says, that looks like a worthy opportunity to take, go for it. So you lie down on that couch, your back pain feels better for a few minutes, and your brain remembers that and says, oh, I got reward. And similar to what Vanessa was talking about, your brain then lays down that couch as a cue as a place where you will get reward. But 2 hours later, you lie down on that couch, and lo and behold, you don't get quite the same level of reward that you got the time before. And you don't get, because that reward system doesn't escalate infinitely. So what do? Your ventral tegmental area looks for the next opportunity to give you greater reward. That may be eating some ice cream. It may be having a cigarette. It may be watching trashy TV. It may be staying on that couch for hours and hours. It may be reaching for more pain medications. But the idea is that people who are seeking quick relief become very readily, who are seeking relief from pain, are going to be very quickly attracted to things that provide them quick relief. Some of those things I described, but also it may just be guarding or isolation or anything that helps to get that pain away, but not things that necessarily portend recovery. So a little more neuroscience here. So I know what you're thinking, which is, well, how does this ever stop then? If you start looking for relief and that always escalates, is there a counterbalance to that? And the answer is yes. You have two different types. I think you have many different types, but I only understand two different types of dopamine receptors in the medium spiny neurons in your nucleus accumbens, your D1 and your D2 receptors. And your D1 receptors are the accelerator. When dopamine hits them, nucleus accumbens says, go for it. Your D2 receptors you can think of as more like your brakes. When dopamine lands on a D2 receptor, it actually inhibits, slows down the activity of the decision-making of the nucleus accumbens. And what does that do? That then gives frontal cortex a chance to step in. So we do have this balance. But the problem is that if we start dumping high amounts of dopamine into these circuits, that D1 pathway becomes very efficient and starts to speed up and makes it much, much harder for those D2 receptors to work. What I found stunning and particularly cruel is not only do you have this now sort of impulsive reward-seeking habit happening, but those same anti-reward neurotransmitters that we saw activated in addiction, dynorphin, corticotrophin releasing factor, norepinephrine, when you're in this situation in persistent pain, those get upregulated as well. Very similar. So what happens when all of these stress peptides get activated? Well, your stress response increases, your mood gets worse, probably your pain gets worse, and therefore your relief-seeking behaviors increase. So can you see, again, as we start to understand people who have this profound sense of distress around pain in our offices, because sort of neurochemically this is what's going on for them. Just briefly, people always ask, the idea with the D2 receptors, and I won't belabor this, is that they respond well to small amounts of dopamine, kind of the little things in life. Huge dopamine surges to D2 receptors essentially knock them out. They sort of get resorbed down into the cellular matrix and either need to get resynthesized or recirculated up to the cell membrane again. So that's why sort of as our ability to seek rewards gets out of whack, we essentially take our D2 system offline and end up with this system that no longer has any brakes. So the implications here, the way I've learned to understand about the healing process, both in substance use disorders and in pain, is that we do need interventions that provide dopamine, but those that are just enough to kind of activate our D2 receptors and facilitate recovery. So you need just enough dopamine to activate those D2 receptors, but not knock them out. The other thing we need to do, in addition to seeking small opportunities for reward to sort of to not knock out those D2 receptors, is we have to reduce exposure in persistent pain to huge dopamine signals. So limiting use of addictive drugs, medications, junk food, any fast-acting analgesic, tobacco. There have been really interesting studies about, particularly among like sort of physical labor workers who smoke, and their propensity for progressing to persistent pain is higher if they're smokers as opposed to if they're not. Again, they've got more sort of dopaminergic agents speeding up their reward pathway. If you do have a need, if your opioid system has become so destabilized over time, buprenorphine, as Vanessa talked about, is a reasonable option to kind of restore balance in that opioid pathway and provide just enough activity in the reward system to allow D2 receptors to work but not knock them out. It has to do with its function of being a partial agonist and not one that's not providing those large dopamine signals. And while you're preventing that exposure to huge dopamine signals, again, to increase exposure to small rewards, which could be, hanging out with your family. It could be effective problem solving, emotional coping. Exercise is wonderful in this regard. So just to summarize this section, this idea that both addiction and pain, relief-seeking activities in pain activate and overstress our reward system. And when we overdo the reward system, all of these anti-reward neurotransmitters are enhanced. In both addiction and chronic pain, I didn't talk about this so much with addiction, but our frontal cortex, our executive functioning becomes impaired. And the healing process in both essentially involves, and this is true for trauma as well, essentially involves rewiring the activity of that executive functioning of our prefrontal cortex, rewiring that back to our limbic system to exert some control over the reward as well as the anti-reward functions. And what I've also learned from colleagues, particularly those who do a lot of work with trauma, is that it's hard to engage in recovery if you don't have an alert, engaged prefrontal cortex. That's why CNS depressants, as appealing as they are particularly difficult in these states because they don't take the prefrontal cortex offline entirely, but certainly you have a lot less engagement when people are more sedated. So the next thing I want to talk about is how did we try to take these concepts, this sort of neurobiological framework, and apply it to an idea of a recovery-oriented persistent pain program. So I'll back up a bit and get a little bit more kind of socially oriented and talk about what I think of when I think of recovery. And again, I'm not an individual in recovery myself, but I've learned a ton from my patients and my colleagues. So first of all, recovery is based on stage of change. It's not black or white. And we didn't look today at the DSM definition of a substance use disorder, but it's a spectrum disease. It's mild, moderate, severe. It's not you're on or you're off. And what this also means, and this is true for pain as well, is that an individual has to be at a state of readiness to engage in recovery-oriented activities, right? That's what pre-contemplation, that's what that whole trans-theoretical model tells us. And I'll pontificate here for a moment, in that I think in our efforts, our well-intended efforts to try to transition individuals who've been on long-term opioids for persistent pain, trying to transition them from opioids to other recovery-enhancing activities, we have lost this idea of motivation. We've lost this idea of what somebody's own individual level of activation is. So we've sort of thought, oh, you've been on opioids for 20 years and I've been prescribing them. Sorry, that was wrong, so I'm going to take those out like you're a Lego set, and I'm going to plop in physical therapy and acupuncture and every other week visits to the behaviorist, and we somehow think that people will respond to that. And some people do. Some people say, great, taper me off, let's try something different. Some people are somewhere in the middle, and some folks are terrified of that. And I think our transitions, particularly, and again, it's all well-meaning, but our efforts to take people off of opioids and get them on more recovery-based activities, we have to be attuned to what their stage of change is. Because I think if we can lose confidence and trust, and people may leave us as providers, but we can also do enormous harm. Recovery, also the same idea, is about an internal locus of control. It's because you want it, not because the provider wants it, not because the insurance company wants it, but because you want it. And sometimes there is an external locus of control. Something else is telling you to do this. But for it to be sustained, it has to be something that you want. Again, this idea of it's a chronic condition. We'll have relapses and remission. Builds emphasize particularly the values of that individual. So for Lainey, for instance, the one value that I managed to listen to before I started trying to do differential diagnosis for her, she likes to volunteer. That might be her most important value. My value might be you can't be on high-dose opioids and benzos at the same time, but we need to emphasize the values of that individual. Building on strengths. And then this idea that basically these other 3 bullet points is that these aren't medical interventions, right? They're not things that happen within the context of an exam room. It happens within the context of people's family, their community, their relationships, and these really aren't medical interventions. And again, that recovery engages the prefrontal cortex and quiets the limbic system. So about 6-7 years ago, I started trying to put all of these pieces together. And I developed this cockamamie triangle, and I won't even go into it. And I was like, oh, you got to risk stratify everything. So I had all these tools and instruments and made everybody fill them out. And then I said, okay, and this is your pathway. And I had all kinds of arrows, and it was nuts. So what I will tell you about now is sort of how we've boiled this down in a way that's more accessible to people. So I tried, again, this idea of habits and routines are not Legos. You can't just insert new ones and pull out old ones. That the real secret sauce here in terms of building recovery in people with persistent pain is engagement, not all my arrows and workflows. We moved much more to emphasizing that individual's values and their function over what their morphine equivalents were. This is a big one. Persistent pain work requires a whole new type of phrasing, and we won't have a lot of time to talk about that today, but I have a wonderful mentor, a physical therapist in Portland, who talks about the use of what she calls anti-inflammatory language to talk about pain. And I haven't created this handout yet because I just stole it from her, but this idea of sort of we use lots of words that are pro-inflammatory, you know, like the ones that Lainey was using. Degeneration, crumbling, collapsing. You have the back of a 90-year-old. Your joint is all gunked up. You've got some major instability. We use lots of pro-inflammatory language as opposed to trying to work on everybody having language that's anti-inflammatory. You may be sore, but you're safe. Pain doesn't equal harm. You may be deconditioned or stiff or achy. This is my favorite. Movement is the best painkiller on the planet. So that was a big lesson, and that kind of language needs to work not only within the exam room, but with medical assistants coming in at the front desk, people who are answering the phones. We did all staff trainings around some basic concepts of pain as well as pain phrasing. More tools. There's really I think there's an important place for risk stratification, but to make it much simpler. And then measurement. So this is a huge one. Pain is really hard to measure, you know, especially if we're not using morphine equivalents. Like, what is the hemoglobin A1C in pain? We don't really have that sort of singular measure that we all look for. So the little advice I'll give to you is just pick any measurement tool. I'll show you the one that we sort of adapted from the brief pain inventory. There's the PEG tool. It doesn't need to be perfect, just pick one and use it. Just so you know how well you're tracking, both for the individual as well as for the population, so you know if your intervention's working. Okay. I'm going to go a little faster. So these are some of the key areas that we worked on. What do we need for the care team? What are some of the modules for pain education that we want to use? What are the resources that we have in our clinic? And how do we make those understandable and available to patients? And then I'll talk last quickly about this idea of a pain care specialist, kind of what I think of as the chronic disease care manager of pain. Okay. So one thing also I should tell you is that a lot of this is developed by, again, these don't need to be high resource intensive interventions. I had a 3rd-year medical student who had been an addictions counselor before med school come to me and say, I want to take a gap year. Can I work at your clinic setting up a pain program? Because you have a lot going on, but it doesn't all tie together. And I said, yeah, sure. And I, for $11 an hour, it's yours. So that's where a lot of this comes from, and these are the things that he developed. Also the reason I bring that up is that he developed this pain toolkit. Some samples are on your tables. These will all be emailed out to you. What we had done with it is we just laminated it and put it in every exam room, so that, as well as for our behaviorists, so that anybody who wanted to use these teaching tools at any time could reach for them. The other thing we did, which is also on your table, is we developed, outside of the toolkit, a separate persistent pain manual. And this was a teaching tool specifically for non-provider staff. For the MAs, the front desk, medical records, folks who answer the phones, because not only the language, but some of the basic concepts of the neurobiology of pain, as well as why we were tapering opioids, we felt it was really important for everybody to have access and consistency around that information. In the toolkit there, you'll see our version of the functional assessment. We just took the brief pain inventory, just the functional interference component, and used that. So it looks at things from walking, mood, sleeping. Again, a nice quantitative measurement of function. Our medical assistants do this with patients like quarterly, I think, when they come in for visits. We developed some dot phrases, which are not very interesting. There's some care pathways in there. And then a little bit about pain education and sort of what's in the teaching tools. And we'll try to play with this a little bit in the role plays, but the idea when you do pain education is just some of the ideas up here. One is to start it early. Don't sort of barrel in with pain education. We always think about asking permission, and you'll see there's pain phrasing at the front of the toolkit that can tell you how you might want to introduce verbally with a patient, and an opportunity for education. A big emphasis on empathy. In the toolkit, you'll see a lot in there about values. This comes from the ideas of acceptance and commitment therapy, which Alexis will talk about more in a moment. There's a checklist there, so that rather than sort of asking somebody, what's important to you? That can be kind of hard in the abstract. So there's a series of values that are there that they can choose from. And then again, using some of the principles of ACT, there's some tools in there that can help people think about, are my thoughts and actions moving me toward my values, or do I have lots of sticky, unpleasant thoughts that are moving me away from them? I'm just going to go through some of these tools for you, but again, the toolkit is pretty self-explanatory. There's work. We have a terrific occupational therapist who talks with us, taught us about pacing, and there's a nice tool in there about this idea of the pacing mountain. And the top of that mountain is where somebody wants to be, but particularly when they're sort of deconditioned, they get sore or have a pain response very early. And then that causes a flare-up. But one of the cool things in this mountain is this idea that your pain response isn't the point where you're having injury. It's not way up here where you're getting hurt. This idea that you're sore, but you're safe. And what we talk about people with pacing is as you gradually increase activity, as opposed to doing all your vacuuming in one day and then you're paying for it 3 days later, as you gradually increase your activity, that pain response will get higher up the mountain, as will your flare-up. People can get their heads around that. Again, we didn't talk that much about this idea of central sensitization, but there's a tool in there trying to help people explain pain in the brain. So pain is an output. It's not an input. It's what your brain is telling you and experiencing. And that's sometimes very hard for patients to hear because they say, you're telling me it's all in my head. It's like, well, yeah, it is for all of us. But for some people, that volume, those signals, your nervous system has gotten too good at delivering those pain signals to your brain. There's a tool in there that tries to get at this idea of trying to uncouple for people this so much of what we've taught them for decades, which is your MRI looks really bad, or your knee joint, your x-rays say this, because we now know there's actually fairly poor correlation between what we see on imaging and what somebody's pain experience is. So there's a tool in there which looks at an x-ray of somebody who has bad arthritis, but that half of people, 50% of people with this degree of degenerative joint disease don't experience any pain. And for this guy with a normal knee, about 10% of people with that knee x-ray have severe pain. So again, trying to get people to uncouple this idea of what they see on imaging and what the orthopedist or me have told them and what they're actually experiencing. There's a tool in there about stress and pain. Again, sort of this idea, that very simplified version of what we talked about earlier, but that as we release more inflammatory chemicals, you have more pain, more stress, sort of a cycle of inflammation. And that if we can quiet the stress response, you get this release of anti-inflammatory chemicals and you have less pain and stress. Another education tool about pain treatment effectiveness. And this is about pain reduction and not functional enhancement, but sort of mapping out from some articles from University of Washington, how much % reduction of pain do you get from physical fitness as opposed to sleep, as opposed to opioids? It's again a very clear, simple teaching tool. And the last thing is, as people, the cover page of the toolkit also sort of highlights lots of things people will say, I can't do physical therapy, it hurts, or they tell me pain is all in my head, or don't take me off of my opioids. So things that we'll probably hear ourselves saying when we do role plays later. So then the toolkit sort of gives you some phrasing about how you might want to respond to that, make a request to give some education, and then points you to which tool in the toolkit will be helpful for backing up your response to what that patient's question is. The last thing that you'll see in there, or another thing you'll see in there which might be helpful, is we have lots of resources, as we mentioned now. They may be within your clinic, or they may be out by referral that we can provide to people for pain. Everything from trauma-related services like EMDR or DBT to a nutrition class. And my thing was always, I would just start signing people, I just send out a bunch of referrals, and that was nuts. So what this tool does is it lets people sort of circle the things in different categories. Maybe it's substance use, maybe it's trauma, maybe it's relationships, maybe it's physical activity. They can sort of circle the things that are of the most importance to them. They can self-select, here's what I want to work on. So I might think for Lainey, boy, your trauma history is the most important thing. And so I might say, I'm going to send you to Lydia. I'm going to send you to the behavioral health provider. She might circle enjoyment of life activities. So again, this idea of letting people sort of self-report, self-select what they want to work on, and then those things can map to a resource page where you can then direct them to the right place to get what they're interested in. The last thing that I want to spend, a few minutes talking about is this idea of the pain care specialist. So in chronic disease, for a good 10, 15 years now, we've understood chronic disease as something which requires care management. It often, requires processes of care and registries, but most important, it often requires a care manager. Somebody who is, sometimes it's a nurse, sometimes it's a behaviorist, sometimes it's a pharmacist, but that person who can meet with the patient, do some engagement, do some goal setting, and then kind of follow up with them on a regular cadence outside of primary care. And we recognize that all patients with pain need access to all this stuff. But some people need a little bit extra. Some people need that care manager, need that individual to help with that coaching and engagement. So these were some of the criteria, and we kept them very broad and very loose instead of my crazy assessments that everybody had to do. Particularly people with persistent pain that they felt was difficult to manage, to function, or to improve. That the PCP or the team had tried all of this stuff with this person and they were kind of stuck and not going anywhere. They may be on high-dose opioids, with or without substance use disorder, may have high knees, missed appointments, poor engagement. But the idea here is that there's this group of people who've been on chronic opioids for a long time that are starting to be called the lost generation. I don't know if you've heard that term. Jane Ballantyne at the University of Washington uses it, and she's a genius, and she's way better, smarter than I am. But I kind of bristle at that term. Like, really? You're resigning a whole group of people to being a lost generation? I mean, again, I work with people who have recovered from circumstances around mental health and substance use and homelessness, who everybody thought, were left for dead. And now now we're working together. So I guess again, a little bit of a bully pulpit here, this idea that there's this group of people who are sort of stuck and they're going to be on chronic opioids with a pretty low function and pretty low quality of life forever, I think we can push back against that. And what has worked for us is utilizing this idea of the pain care manager, who incidentally, to start out, was that same third-year medical student who I didn't give him $11 an hour, but it's now one of our licensed clinical social workers does this role, but I really think it could be any variety of people, because these were some of an overview of the attributes that he thought was important, particularly training and education, trauma, motivation, and then some of the skills Alexis will talk about here in a moment. But the biggest thing, I think, and this is why I think this could be a fairly broad-based role, is that the biggest idea here was on engagement and relationship building. And I'll show you a little bit about that in a moment. And then he would sort of move through this process. Once he was able to establish that relationship, then you could start to focus on values. Then you could start to set goals. Then you could start to refer people. But this is a long, slow process. And these are some of the things that Justin, the med student, told me as he left. He said, the time just from referral to when someone might show up to meet with me, that alone might be 2 months. Okay, so there's a lot. Think about pre-contemplative people. It takes a lot for them to get to just an appointment to show up. But then this point down here, then by the time we had sort of moved through that cadence on the previous screen of building engagement and values and identifying goals, and then seeking out other resources in the clinic or elsewhere, that alone might be then another 3 or 4 months. So really 6 months before a referral is placed, before someone actually feels safe and motivated and trusting enough to say, yeah, maybe I'll go to a physical therapy appointment. And I thought this was brilliant. He said, much of my time is just holding that space for people's frustration and anger and, frankly, terror around having had a certain way of coping for 20 years, and now that is about to change. So just to sum up here in my last 30 seconds, as you embark or continue on your own persistent pain work, these are some of the simple things I've learned over the last few years, just to identify a few principles that will guide your work. They may be recovery-based, they may be from some other orientation, but then build some guidance and tools and practice around those principles, and tools that the patients can choose from, providers choose from, and that encompass the entire, really the whole clinic. Again, pick any measurement tool and use it, just so you know you're making a difference. And also, if you're wanting to justify ultimately to payers why we need to continue this grant for this care manager, whatever it may be, those data are particularly important. And again, I think if the biggest thing to say today, remember one thing is, if things get stuck, if people get stuck, the secret sauce is time and engagement. So that's all I have. I don't know if I have time for questions. We may save that for the panel. But my email is there. Again, we're going to get these materials out to you. But if there's anything else that I mentioned that would be of interest to you, don't hesitate to email me and I can get it to you.
Thank you so much.